Hello, and welcome to the CAP Today webinar for Wednesday, August 3rd. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host, and I'll also moderate a question and answer session after our formal presentation. Today's important webinar is entitled Community-Based Rapid NGS Offers Considerable Advantages in Clinical Cancer Care. This webinar, I want you to know, is made possible by a special educational grant from Thermo Fisher Scientific. We want to acknowledge them, and we want to thank Thermo Fisher for their support and help in bringing you this very, very important session. Our speaker today, and I'll say more about him in due course, is Dr. Brandon Sheffield. He's at the William Osler Health System in Ontario, Canada. But before we begin, as always, I'm going to share a few housekeeping items and tips that I hope will enhance your enjoyment of our session. We often suggest that you go ahead and refresh your browser. Also, if you look in the lower right-hand corner of your computer screen, you'll see a toll-free number. We have live help available throughout today's webinar, and you can get technical support easily by calling 858-345-5916. If you have technical questions either with the computer website or with the audio, of course you can also use the Q&A box that you see there below the slides and type in your questions or comments, and again, you'll have live help available throughout the day. Of course, the Q&A box is principally there for you as participants to ask your questions, make your comments. You can do that throughout today. I will hold those and triage those throughout the hour, and then I will begin a question and answer session once we give Dr. Sheffield a chance to catch his breath after his formal presentation. And without further ado then, I want you to know, of course, we are going to post the audio and slides in about a week or so after today. We'll post those on captodayonline.com. You'll likely see some follow-up email from Thermo and from us, so I wanted to alert you to that. Finally, as always, you do know that CAP Today does not endorse any product or service that may be mentioned in today's webinar. And of course, any comments that I may make are purely personal and not to be taken as policy of the CAP Today or the College of American Pathologists. And so with that, let's turn to our main event. Our speaker today, as I mentioned, Dr. Brandon Sheffield, is an anatomic and molecular pathologist at the William Osler Health System. He went to school at the University of Toronto for medical school and did a path residency in Vancouver, British Columbia. He's been with the William Osler System since 2017, and he started an advanced diagnostics department, and he's the leader of a great deal of scientific research at the William Osler Health System. So it's our delight to have him, and I will invite Dr. Sheffield to begin his presentation now.
Thanks so much, Bob, for the great intro, and thanks everybody for joining in today. I know we had a date change, so thank you as well for those who have been able to accommodate that. I'll be speaking today on point-of-care molecular testing, and over the next hour, we'll really discuss exactly what that means using our own health system and hospital as an example. So thank you again to Thermo Fisher, whose sponsorship has made this possible. And again, the views presented here are my own, and the opinions are my own. Here are my financial disclosures. Now, I'm joining you today from the Toronto area of Canada. Just to give you a sense of where I'm from, I know the audience is from all over the world. I work in a community hospital called the William Osler Health System. This is a network of 3 large community-based hospitals, and all of the laboratory work is centralized at one facility. And we offer full-service laboratory care to support full-service hospitals. This is me at work. My background is as an anatomic pathologist, and I like working in community practice where we actually do a general sign-out. So we'll look at everything from skin to breast, GI, and anything that comes our way. We also have recently introduced molecular diagnostics, and we sign that out together with our anatomic pathology work. So during this talk, I'd like to use lung cancer as an example disease for how we do biomarker testing. And I think that lung cancer makes sense to use as the best example because in Canada, where I practice, this is the #1 leading cause of cancer-related death. In fact, lung cancer kills more Canadians than the number 2, 3, and 4 causes of death combined, and those are breast, colon, and pancreas cancer. And depending on where you're listening from, the same or similar may be true in your own region. In addition to being the most common cause of cancer-related death, we're responsible for a very large number of actionable biomarkers which we need to test. Some, like PD-L1, are done by immunohistochemistry, but others, genetic markers such as BRAF, EGFR, ALK, and the list goes on, have to be done by other methods. And regardless of whether you're practicing in Europe, North America, or other jurisdictions, and regardless of what our regulatory body says is mandatory, there are a large number of biomarkers that we're responsible for. Here's my own personal list of at least 11 biomarkers that we're responsible for reporting to our oncologists every time they treat a new lung cancer patient. And just because we're talking about lung cancer doesn't mean it's the only disease like this. Other disease sites are certainly emerging, and colon cancer is not far behind at all, where we have upwards of 5 different first-line systemic therapies that will be predicated on the biomarker results that we provide to our oncologists. So when we think about developing a biomarker testing for solid tumors and for lung cancer in particular, these are some of the statistics that are front of mind for me, is that 70% or the majority of lung cancer patients will present at an advanced stage. They tend to actually come into the hospital in extreme condition, really requiring a lot of intensive treatment, and they need to get started on their systemic therapy as soon as possible. The death rate of untreated advanced lung cancer is 4% per week. So I like to keep that front of mind when we're working out the logistics of how our biomarkers are going to be delivered, because patients cannot get started on treatment without their biomarkers, and they'll be looking at that higher mortality rate until we can issue those results. So to that end, we have guidelines all over the world indicating that lung cancer biomarkers have to be done quickly. This is our Canadian guideline. It says the exact same thing as European and international guidelines. However, it comes with this nice picture, and it really maps out that 10 days is the time required for a molecular lab to perform these biomarker results. 10 business days is 2 weeks in real time. And one of the issues that we face, though, in a community practice is that it's exceedingly difficult for us sometimes to get the tissue to a molecular lab. The time we're given in this guideline and others is three business days. However, it's very difficult for many community labs to actually meet that. And then on the post-analytic side, we're told that we need to get the information from a molecular lab into the hands of our oncologists in 1 day or less. And that, again, is very, very difficult to achieve. Many labs are not able to meet that standard. So here's an example from my own practice that I remember quite well. This is a patient who presented in early November, just like a classic lung cancer presentation, where he came to the hospital very sick through the emergency room and was admitted to the oncology ward. It took 1 week or more to get the sample sent out for EGFR testing. That was what our process was like at the time. And we received an email from an oncologist indicating that the patient was very, very sick. He was so sick that he would not have been a candidate for systemic therapy like chemotherapy, but he might have been able to receive a targeted therapy, which are generally more tolerable when patients have a low or a poor performance status. We tried to do whatever testing we could by IHC that we had available at the time. None of these were helpful, and the patient passed away. And a month after he died, we found that he was EGFR positive when his next generation sequencing results came back to our lab. It took a total of 62 days from the time of diagnosis to receive that result. And believe it or not, that is actually the expected time frame for us when we're sending out biomarker tests. Typically in a Canadian setting, a community hospital would send out results to an academic hospital within the same region, and that's exactly what we expect, is approximately 2 months turnaround time, and all of our patients were faced with the same. But we found that there was a positive signal here, and that we were able to get IHC biomarkers out within a day, pretty much. And so we wanted to explore that a little bit further and see if we could offer some further biomarker testing, because we, at the time, we could do things like ALK, ROS, UREP. We could take this very far by IHC, but we're limited as markers like EGFR don't have appropriate IHC to use. So, again, I sit here as an anatomic pathologist. We work with our oncologists in our own hospital, and we're able to get IHC very, very quickly. Things like diagnostic IHC, like TTF1 or keratin stains, we tend to get them in the same day. Here's an example of a diagnosis from my own practice. This is a breast cancer. And you can see there's not just a diagnosis of invasive ductal carcinoma, but we're giving the ER, PR, HER2, and IHC biomarkers together with that same diagnosis. To me, this is very powerful. And when a patient is diagnosed in this way, the diagnosis is inextricable from the biomarker results. So in a way, the patient's not being diagnosed with breast cancer. They're being diagnosed with hormone receptor positive breast cancer. And anytime a practitioner looks up that diagnosis, they'll be forced to look at the same biomarker results, which are present in the same document. And this really helps steer the patient's cancer journey in the right direction. Now, this is possible because of these people, one of whom, whose fingers you can see in this photo. This is a medical laboratory technologist, and she is cutting a tissue biopsy at the microtome. So that's a biopsy right there. It's embedded in paraffin wax, and this is a block for those of you who don't work directly in an AP lab. And what she's doing is this machine is moving up and down against a very sharp knife, and she's cutting individual sections of that biopsy to be made into slides or to do other tests with. Now, this process is identical for diagnostic slides like H&E and keratin stains as it is for IHC biomarkers like ER, PR, or PD-L1 in a lung cancer. So because this is being done by the same individuals in the same facility, we get our results very quickly. Conversely, when we look at our molecular results, we tend to send them through a very convoluted pathway. And this is why they take over a month. So if you're a pathologist sitting here in the community, once you make a lung cancer diagnosis, the entire case would get shipped out to an academic hospital where it would then be accessioned and reviewed by another pathologist. That pathologist would have to assess the tissue for tumor content, cellularity, and possibly do IHC biomarkers like ALK or PD-L1. They would then ship that outside of their histology lab into a separate molecular facility. And once the tissue gets to that separate lab, we would do things like DNA, RNA extraction, prepare a library, gene sequencing, the computer-related steps like bioinformatic analysis, and then an individual would sit down with all of these variants and write a report saying which of them are important and how these might impact treatment. What we typically see after that is that the results go back to that same anatomic pathologist who would sign off on these, possibly correlating them with IHC biomarkers like the PD-L1. And then those results would be faxed back to the original pathologist, who would then actually retype them into an electronic medical record and issue a report to their own oncologist. And that process, in general, takes several weeks. So what we set out to do is teach our IHC technologists to do NGS. And to accomplish this, we used a highly automated gene sequencer, which was easy for them to use. And we validated an off-the-shelf 50-gene panel. Of course, because this is brought in to clinical practice, we underwent a very stringent validation process to make sure that this was fit for use in a clinical setting. And what we found is this particular panel had a very, very high concordance to reference methods for single nucleotide changes, for copy number alterations, as well as for RNA-based fusions. And we validated this in small biopsies, cytology specimens, surgical specimens, the general milieu of what we experience in a pathology practice. And while I can't show you all of the validation, I would just show you this one highlight, which I thought was very informative for myself. This is where we're looking specifically at the ability to detect NTRK fusions and comparing this panel that's being performed by IHC technologists with other commercially available panels. And I think that for me, I generally look to the Archer FusionPlex as a gold standard for fusion detection. And depending on the screen you're watching on, you might not be able to read the individual words on this slide, but these along the y-axis of each chart are individual NTRK fusions present in this commercial control. And you can see the Archer FusionPlex is able to detect all of these present at a high level. However, as soon as we dilute the sample with wild-type RNA, we'll see some dropout of the ability to call these fusions. And then when we dilute again to a 1 in 25 concentration, and that's, we believe, representative of what we generally face in practice, you can see that this panel misses quite a few of these results. And then another relevant one to compare to is an assay like this, early generation Oncomine assay, where we see the panel is able to detect NTRK fusions way out to a very low concentration. However, there's certain fusions that are just not included in the panel itself. So regardless of how concentrated the RNA is, we'll see a failure to detect those particular fusions. And this is the panel that we're using, and we thought that it validated out quite nicely with a good mix of comprehensiveness as well as this so-called real-world sensitivity at a low level, or to be able to detect fusions at such a low level. So when we got this validated, what we were able to do is combine library preparation, sequencing, and bioinformatics into a single automated instrument and place that right here in a community setting. What we had to do in addition is train the technologists in DNA RNA extraction, and then we had to train our anatomic pathologists to be able to report these variants. So once we were able to accomplish all of those, we could offer next-generation sequencing in this community setting and deliver it in an analogous fashion to IHC. And what I'll show you over the next few slides is how that changed practice at our hospital. So we pulled for analysis the first 500 cases that we looked at, or just over 500 cases. Over half of these are lung cancer, with several other disease sites represented as well. And as further validation, one thing that's very useful is to monitor the prevalence of key driver mutations in lung cancer. So even though the panel is fully validated for clinical use, it's further validation to see things like our EGFR rate at 17%, which is exactly where we expect that it would fall. Same with other sentinel events like our ALK fusion rate, around 3%. So there's further validation that the assay, as well as the people using the assay, are performing as expected. Looking at colon cancer drivers, we can see the same thing. We expect about 50% of our colon cancers to be KRAS mutated. And an interesting fact about colon cancer is that compared to single gene testing, which we were using in the past, switching to next generation sequencing actually allowed us to detect actionable driver mutations in colon cancer more than 10% of the time that would not have been identified by single gene testing methodologies. Now, I think that the biggest impact of having the NGS available on site in this point of care fashion was the turnaround time. So overall, over these more than 500 cases, we had a median turnaround time of 3 days, and 50% of the cases or more were done between 2 and 4 days. And remember, we were coming from a system where it took over 2 months to get biomarker results. In addition to that, you can see a number of cases were turned around with a 0-day turnaround time, and I'll show you what that looks like in a moment. And then an additional small number of cases had a 1-day turnaround time. This was probably the hardest to achieve, and these would reflect stat results or stat requests from oncologists, either for sick inpatients or various other reasons. So you remember this breast cancer that we looked at towards the beginning of the talk, where the diagnosis was attached to the biomarker results, and now we can actually do the same thing for lung cancer. So this patient was diagnosed not with a lung cancer, but with an EGFR-driven lung cancer. The biomarker results are from the exact same document as the diagnosis. So anytime a clinician pulls this diagnosis, they will be stuck permanently together with those biomarker results. And this would be an example of a 0-day turnaround time report. The pathologist would have received the slides with their regular sign-out, and they'd order an NGS test together with their diagnostic IHC, like a TTF1 or a P40. So when you have this available in your lab, this can really open things up to the pathologist in terms of activating them as a member of the care team. And this is a case from a colleague of mine in cytopathology. She made a very unfortunate diagnosis of lung cancer in a 28-year-old man admitted to the intensive care unit with a widely metastatic disease. She made this diagnosis and on actually a bronchoalveolar lavage or washing, and there was very limited amount of material, limited to just cytology slides with no additional material to work with. When she recognized what was going on, she ran straight to the molecular lab and asked if the material could be subjected to DNA, RNA extraction. And rather than attempting to confirm the diagnosis with any immunohistochemistry or traditional diagnostic markers, she confirmed the diagnosis by performing NGS and documenting a ROS fusion. And because of that quick action, this patient was able to get on a ROS inhibitor and leave the ICU, which we don't believe he would have been able to do otherwise. And now I'm just going to show you a couple of emails. These are from my own email account, and we often joke that our email account has more evidence and more scientific data than some of our electronic health records. So we decided to reproduce some of these just to give you a sense of what this has been like for our oncologists in their practice. These are reproduced with the oncologist's permission, but the patient's names have been removed. This one is from my colleague, Dr. Parneet Chima, who's our chief of oncology and one of the best in the business. I think that this email in particular is really, really great and speaks volumes to what we've been able to achieve, as this is addressed directly to the histotechnologists who perform biomarker testing. There's no form, there's no fax, they're not going through secretaries or any of the middlemen who would otherwise slow down this process. And I think it's great that she refers to our technologists as her team. She's further able to triage her own results. And when you have interactions like this between lab technologists and world-leading oncologists, she's actually able to do some light teaching by indicating that there's a special histologic subtype of this lung cancer, and that this histologic subtype is highly associated with certain driver mutations. Now, note the time that she makes this request. Unfortunately, she just missed the boat, and our NGS run would have gone off probably by 9 a.m. that morning. But 2 minutes later, we're able to let her know that it'll be on tomorrow's run. Within 5 minutes, the technologist is able to pull the tissue and have it ready for review. Remember, this would have had to take about a week using the old system to get this into a new hospital. And just over 2 days later, we can confirm that the patient has a MET skipping mutation, just as she had predicted. And the reason she thinks this is really great news is because these patients are amenable to treatment with targeted therapy. This is not the same patient, but this is one of the first patients in our hospital we treated with MET exon 14 skipping. You can see she had about a tennis ball size tumor here and one the size of a golf ball here. But after a few months of MET targeted therapy, she actually had a complete response. And this was several years ago. This patient is still enjoying that same complete response. So here's another example. This is from Dr. Ravia Singh, another oncologist in our center. She's actually asking about a liquid biopsy, which we're also offering at this point. She had it drawn on May 9th and didn't get any results by May the 12th. So she's emailing to see what's up. And actually, we had a situation in the lab where we ran out of a certain reagent that we needed to extract the DNA and RNA from blood. And so we decided to hold all of the specimens and wait till we got emails exactly like this so that we could triage out the most urgent cases using our last remaining reagents. And so this plan worked perfectly. We explained that to Dr. Singh, and she said, yes, let's go ahead. This patient needs a result as soon as possible. So by 11:30, we're able to authorize this to go ahead for extraction. That's acknowledged by our tech. And actually, this is just 22 hours after the initial request, so it's a less than 1 day turnaround time. This patient was found to have an EGFR exon 19 deletion on liquid biopsy, and that allows us to make a diagnosis of metastatic pulmonary adenocarcinoma, as that particular mutation is not typically seen in any other tumor types. And it simultaneously allows us to tell the oncologist that the patient's treatment should be an EGFR tyrosine kinase inhibitor. So with one test in less than 1 day, we're able to make a diagnosis as well as a treatment recommendation and spare this very sick patient the need for any tissue biopsy at all. So the oncologist was very happy with that result. But the point of these is just to show that, when we have NGS available at our fingertips, this really improves the working relationship between a pathology lab and oncology clinic. And it means that we can really interact with our colleagues in real time and play a more meaningful role in this team. One additional thing that I just want to bring up before we move on to questions and further discussion is the economics of this. And that's often a barrier that we face when we're trying to implement NGS testing or comprehensive biomarker profiling. And this is certainly something that I faced as well when we tried to implement this. But it's very important to try and de-silo the different costs that we look at. So a lot of focus is spent on the material cost of NGS testing, things like the chemicals, the plastics, the other consumables. However, what we need to focus on is how much money we're saving on things like shipping, transcription, oncology visits that are purposeless because they're attended with no biomarker data, and as well as the cost overall to our healthcare system of providing supportive care to sick lung cancer patients while they wait for those biomarker test results. And I think when we're able to take a step back and look at the bigger cost or the bigger picture, this style of NGS is not just fast, but it's very much cost-saving for the health system as a whole. So again, I just want to thank everybody for their attention and thank our sponsors again for making this possible. It was really great to get the chance to share, how we've been able to implement rapid NGS and the effect that it's had for our patients. And in conclusion, this is possible to do. It can be effectively integrated with a histopathology practice so that we can provide NGS in an analogous fashion to the way we provide IHC. And this not only helps with predictive biomarker testing, but when the pathologist can work this into their practice, it actually becomes a very useful diagnostic aid. And we've seen that with diseases like carcinoma of unknown primary, ordering NGS up front can actually be often more helpful than a large battery of immunostains. And it really, most of all, activates the pathologist as a part of that precision oncology team, and it makes us a much more meaningful part of that multidisciplinary group. So thank you again for your attention, and I'd be happy to take any questions.
Dr. Sheffield, thank you so much for that wonderful presentation. I don't think I'll ever make a nasty comment about email ever again. I think you've got a secret here that you're sharing, and it's highly, highly useful. And nothing could be a better or more dramatic presentation of the benefits of having NGS right at your fingertips. We've got, of course, several questions and comments. Everyone is impressed with your turnaround times to have one day. Would you care to go back in your experience? Were you also surprised at how easily and quickly the turnaround times worked once you had the instruments on site?
Yeah, we were very pleasantly surprised by this. I'm very lucky. I get to work with some of the best medical lab technologists in the world. They're very dedicated, and they really view themselves as essential healthcare workers and part of the cancer care team. So we already had that work culture, which I think was very important. And I think that we take a lot of pride in providing our IHC results so quickly. So, really the key was having the ability for them to expand their practice into molecular testing and using instrumentation that was easy enough for them to use without any previous experience in wet molecular work.
Yes, thank you. Tell me now a little bit about your oncologist, because clearly they're very much up to date. They're very knowledgeable on the basis of the emails I've seen. Did you have to do a lot of work with them to explain how the process would change?
Yeah, that's a really good question. And, I think that engaging with your oncologist is really key. Biomarkers are precision cancer care is really the interface between laboratory work and clinical oncology. And you need to have both groups working together in order to achieve high quality precision cancer care. So, not just next generation sequencing, but any biomarker testing program really needs to have input from the clinicians who are going to be using these results. And for them to be successful, we need to make sure that these are done in such a way that it works well for the oncologists and fits into their own practice. you can have leadership in precision cancer care from within the laboratory or from within the oncology clinic, but you definitely need both sides to be active participants for this to work well. And yes, I'm very lucky as well. I get to work with some of the best oncologists in the business. They're very up to date, and many of them are thought leaders in terms of precision medicine.
Thank you. Now, I'm sure you'll remember sort of a wave that happened, maybe 6 or 7 years ago, where they were talking about having molecular tumor boards. Clearly, we've advanced well beyond a separate molecular tumor board for cases. I'm assuming that's true in your institution, correct?
Yeah, so I have been a part of molecular tumor boards in the past, and these are really great events. It's really critical, I think, for our own education, especially if we're not molecular people, to get a chance to discuss what these findings mean and to put them in the context of different treatments. It also gives us a chance to activate our laboratory geneticists and bioinformaticians and bring them into a more frontline healthcare worker type of role. And this is a great way for people who are mostly within the laboratory to get out and experience what things are like for patients. The system that we use is that we have site-specific tumor groups. So we have a thoracic tumor board or a colorectal tumor board. And this process of democratizing the NGS results has really allowed our pathologists to take a lot of ownership of that information and become the ambassador for the molecular results. And they're taking that increased knowledge, ability, and confidence and bringing it into these site-specific tumor boards, which has really been helpful because they're often the ones who might have signed out the particular result, and then they can speak to that molecular result as well to the multidisciplinary team. And I think that's really critical because even though molecular tumor boards are great, our molecular genetic pathologists or subspecialists in that area can't possibly discuss every cancer patient in the hospital. So having the anatomic pathologists fill in where they can, I think has been very effective, at least for our group.
Thank you. And along that line, let me get into the processes in pathology. First, could you talk about any challenges that you're facing in the pre-analytic phase in this setup that you currently are using?
Yeah, so to me, there's two pre-analytic phases that I think of. One is the specimen as a whole. When this comes from radiology or endoscopy or the operating room, just getting this into formalin in an appropriate time frame, making sure it doesn't stay in formalin too long, and those processes we have a very good handle on, because remember, our background is from immunohistochemistry. We work in a surgical pathology lab, and so those are the pre-analytic factors that we really have tight control over. We're in the same building as our surgeons or our radiologists, so it's very easy for us to intervene if there's any problems on that type of pre-analytical side. When we got into next-generation sequencing, we experienced different type of pre-analytical conditions. These are things that I would consider like DNA and RNA extraction, looking at tumor cellularity and tumor content, and these were often new concepts to either our pathologists or our histotechnologists. So really the challenge there was educating our pathologists on what appropriate cellularity looks like, getting practice at estimating tumor content by eye, and then correlating that with the type of allelic fractions that we see in a next-gen sequencing result. And then again, even though we were able to find a sequencer that does most of these steps in an automated fashion, we still did have to teach our technologists how to prepare a sample from FFPE into DNA and RNA in a test tube. And that meant teaching them how to deparaffinize, how to digest the protein, and ultimately how to extract DNA, RNA, and then to quantitate that and quality check to make sure that it's appropriate for gene sequencing. So most of those pre-analytic conditions in that sort of pre-NGS were fairly easy to move through, but they just required education and explanation to the relevant stakeholders to make sure they knew why they were doing these things, and that's really all we needed to do for them to complete the rest of that and make sure these specimens are coming through in top-notch quality.
Good. There's several questions around this area, and I'm led to ask you the question, does having the NGS system, as you say, at your fingertips on site, does that make the comprehension and training and even the reluctance, does this help by having it on site as opposed to having it as a pure send-out, which might seem a little intimidating in terms of understanding all the steps in the testing process? Am I clear?
Yeah, I think that's a good question. So when you're sending out NGS, like most community hospitals do, it takes a long time. And I think that in itself is what really hampers the education and the ability of pathologists to gain a better understanding of the NGS and how it might help their practice. So if you had a particularly challenging case and you send out for NGS and you don't see the report for over a month, really the question is gone from your mind and you've forgotten about it and are on to new problems and new issues. So it really limits that ability. When a pathologist can look at a case under a microscope, order NGS, and have the result in their mailbox the next day, I think they really gain a very good appreciation for the relationship between what they're seeing under the microscope and the actual results of the gene sequencing studies, because they can correlate them in real time. And oftentimes we need extra tests like IHC markers anyways. For biomarkers, they're necessary to get things like PD-L1 and lung cancer, ER, and breast cancer. So we're having to do the IHC step anyways. Having the NGS right beside them at the same time they're looking on the microscope really makes these things, it really boosts the ability to learn and to better understand that interplay. And what we've seen with our pathologists, which is it's really wonderful to see how they embrace the technology, because they immediately recognize situations where ordering a quick NGS can actually help them with their own job, not find a treatment for the oncologist to use, but it can help them get over a dilemma for their own pathology report. Like they can use this to better assess questionable margin. They can use this to determine stage between two tumors that might be new primaries or metastases of one another. They can even use this for atypical cells, which we're not sure if they're being reactive or neoplastic in nature. Getting a quick look at if there's any common mutations present in these can be a very helpful diagnostic boost, and it did not take our pathologists very long at all to figure that out.
Understood. In a certain sense, by having this at your fingertips, you take a lot of the mystery and even fear out of combining the NGS so easily with the microscopic examination, correct?
Yeah, exactly, and that's the idea as well. And the microscope exam can actually help us better interpret our NGS results as well. So we're finding that the two tools are very complementary to one another.
Yes, and I'm sure you would say also that, everything has to begin with this assessment of the tissue. We sometimes hear people fearing that actual tissue assessment, may be antique, but by no means is that the case, correct?
Sorry, could you repeat that? I just missed the...
Well, there is some fear that's been expressed over the years that with NGS, this eliminates the need for actual tumor and tissue assessment at the scope. But in fact, they really do go together, correct?
Yeah, we see that a lot, and there's a fear that maybe the traditional histomorphology might be becoming obsolete, and I don't feel that way at all. But I view myself as a laboratorian, and we have to provide whatever test is going to provide the best possible laboratory care for our patients. So in the solid tumor world, that's the microscope. And we can give a substantial boost by offering next-generation sequencing in addition to that. I think that the traditional practice where NGS data is kind of locked away and difficult to access for the majority of cancer patients, it really does them a big disservice. So if we're able to, in a community setting, and in Canada, about 90% of cancer patients are treated in a community setting. So if we're able to take that very helpful tool and make it more available to our patients, then I think we're doing a good job as laboratorians.
Very good. And I did want to give you a chance to speak a little bit more about your initial steps in liquid biopsy.
Yeah, I mean, so liquid biopsy it's very interesting. It is definitely a hot topic right now. Cancer patients are aware of this, and they want to use this. Oncologists are aware of it, and they want to use it as well. The instrument we're using and the panel we're using does have the ability to either test an FFPE, a tissue sample, or a blood sample for a so-called liquid biopsy. One of the surprises that I had was that we launched our tissue assay first, and the liquid biopsy came a few months after that. When the tissue biopsy was available and we were able to get NGS results so quickly, the demand for liquid biopsy really evaporated. And we saw that that a lot of oncologists were using liquid biopsy because of the speed and difficulty accessing tissue-based NGS. A lot of liquid biopsy is done through send-out to private companies rather than to other hospitals. And simply by offering the very rapid turnaround, we saw a massive drop in our requests for liquid biopsy. And we still offer this, but it's limited to those patients where we truly have no tissue available and the patient would be too sick or too unstable to undergo a tissue biopsy procedure.
Thank you. That's fascinating. Let me ask you this now for your pathologists. We all know about tumor heterogeneity or cases where there's very low tumor cellularity in the specimen you're dealing with. Are your pathologists identifying tumor on H&E sections for microdissection in order to improve the tumor content and purity for NGS analysis?
Oh, so that's one area where I think we have a huge advantage using this type of workflow because we do not need to cut additional H&E slides. We would have the H&E slides available from the time of diagnosis. Because we're asking our pathologists to read the NGS results and interpret them, these are the same individuals who will be reading IHC biomarkers and things like MMR on colon cancers or PD-L1 on lung cancers. So we're actually able to get more utility out of those IHC biomarkers. They give things like a PD-L1 result, but also a morphologic study to help control the tumor content and cellularity. So that actually helps us conserve tissue in these very scant biopsies. And with diseases like lung cancer, the biopsy is often very limited in its size, and there's a limited number of sections we can get from it. So using things like PD-L1 to assess tumor content can be very helpful. In general, we try and avoid macrodissection And the assay that we're using is validated to a tumor content of 5%. So as long as we have 5% tumor content, most of the biopsies do achieve that. We're comfortable with the calls that are made. Of course, that's mostly for single nucleotide changes and insertion deletions events. With copy number alterations, the more tumor content we have, the better. And with RNA fusions, as far as we can tell, this will work to a very, very low amount of fused RNA present. We think that the assay, although it's difficult to prove exactly, will work down to just a few molecules getting included into that RNA for the NGS test. The other advantage here is that the technologists loading the instruments are actually the same technologists who would be cutting the block and performing that diagnostic IHC. So they are our biggest ally in making sure the tumor cells make it from the block onto the gene sequencer. And so sometimes if we're trying to do something that there's not enough tumor content, they'll be the ones to spot that and to help us out.
Thank you. People are very, very intrigued with your practice, and they're wondering where the next steps are for you. Do you plan to extend your biomarker testing for disorders of blood?
Yeah, so the panel that we're using right now, it's very good for lung cancer, for colon cancer, for melanoma. We would very much like to offer this for patients with myeloid neoplasms, or even a question of a possible myeloid neoplasm. And then we're also looking to add additional NGS testing that will be more suitable for patients with genitourinary or gynecologic malignancies as well.
Very good. And I assume you keep one eye fairly closely on the development of the targeted therapies and the relevant biomarkers for those therapies, yes?
Oh yeah, that's the bane of our existence. We're only just we're one ASCO or ESMO meeting away from having to go back to the drawing board and redo everything. So we do have to keep a close relationship with our oncologists, and we try and get as much lead time as possible. If there's going to be a new marker, a new drug, or a new test that we're going to have to perform to enable our patients to continue to get the best possible treatments.
Understand. We still are getting some persistent questions about how much molecular knowledge does a general pathologist without molecular training, how much knowledge do they need, and what resources do you bring to your colleagues to help them with this?
Yeah, I can understand why there's a lot of questions on that. Is that this represents a new skill that we might not have had any training on at all during our formal residency programs. And every pathologist is different. Everybody will need a different amount of training in order to provide these results for their patients. I do believe that any pathologist can be trained in this, but some of us will need more and some of us will need very little. The additional resources that are helpful, I think just attending the tumor boards, talking to the oncologist, and finding out how they're using these results is probably the best possible resource to use. And then outside of that, I would just look for any molecular courses at the conferences you attend. There's always some great ones at all of the major pathology conferences. And then having one person in the department with a bit more in-depth knowledge is very, very helpful too, because that way that person can do the more difficult cases, the more challenging cases. The majority of results on a 50-gene panel are fairly straightforward, but you want to have somebody who you can ask if you get something weird or strange that you've never seen before. And if that person's not necessarily in your department, they might be at a nearby hospital, or some other arrangement can be made, just so that if you have a result that makes you uncomfortable, you're not necessarily on the hook with it.
Thank you. That's a terrific answer. I'd like to add just to our participants, some of whom I recognize, there was a time when IHC had almost the same mystery about it and concern about interpretation and training. And NGS, I think, is following in line.
I think that analogy is perfect, and I remember the multiple stages to do a manual IHC and what a change it made to have a fully automated IHC machine, and that meant we were able to offer this important test right within the laboratory and right close to where the pathologists are signing out. And I see the automated NGS as very analogous to the way we've embraced automated IHC stainers.
Yes, I'm glad to hear that. And with that, I think I'll go ahead and begin to bring us to a close. We've really had a magnificent webinar today, and this whole field is moving quickly, and I think we've had as good an update as it's possible to have. So I would like to start, of course, by thanking Dr. Brandon Sheffield. A wonderful, wonderful presentation. You can see it and share it and view it again in about a week at captodayonline.com, and you'll enjoy it all over again and share it with your colleagues, I hope. Also, of course, in addition to Dr. Sheffield, I want to thank Thermo Fisher Scientific for their special help in bringing us this important webinar today. They've been a very, very good partner with us for quite a while now, and we're always very grateful to them and happy to be working with them for these webinars. Finally, I want to thank all of you. You've taken your time out of a busy day in August and to join us. We're very, very grateful that you take the time to do that. We trust that you find these valuable, and we look forward to presenting other webinars to you in due course. So with that, just to wrap up once more, I want to thank Dr. Brandon Sheffield. I want to thank Thermo Fisher Scientific, and I want to thank this audience for participating with us today. And with that, I will bring today's webinar to a close. Thank you.